Hey, good afternoon, everybody. I'm just going to give it 5 seconds for folks to join as they come out of the previous session. I see folks are joining right now. So I think we can get started. Welcome back, everybody. Thanks again for joining us. For those who haven't sort of met me virtually yet, I'm Mike Hekwich. I'm the director of the Champlain Center for Healthcare Ethics, and I'm very pleased to be introducing our next speaker and moderating our final presentation from what has been, I think, a very successful couple of days of sessions. So I think everybody is intimately familiar with the housekeeping items at this point, so I will not belabor them. Our last presentation is titled Organizational Response to Disease Healthcare, and it's going to be presented by Dr. KELLOWAY over the next 30 minutes. So we're very excited to have Dr. KELLOWAY join us today. He is the Canada Research Chair in Occupational Health Psychology and a Professor of Psychology at St. Mary's University in Halifax, Nova Scotia. He received his PhD in Organizational Psychology from Queen's University in 1991 and began his career in the Department of Psychology at the University of Guelph. In 1999, he joined the Faculty of Commerce at St. Mary's University as Professor of Management and Psychology. In 2009, he was appointed as the Tier 1 Canada Research Chair in Occupational Health Psychology. He is a prolific researcher, having published over 200 articles, book chapters, and technical reports, in addition to 14 authored or edited books, and he is joining us from Eastern Canada today. So welcome, Dr. KELLOWAY, and thank you for being with us. I'm going to hand it over to you.
Thank you. So it's a pleasure to be here, albeit remotely. Frankly, I'd rather be at Ottawa because I always like going there, but we'll make do. So as mentioned, I'm going to talk about a program of research we've been involved in for the last year or so. So the presentation will move through a couple of phases. I'll tell you first about the sort of big project and what we've been doing over the last year since we started this just over a year ago now. I'll tell you a bit about what we thought we were going to do and then what we actually ended up doing as the situation unfolded. And then I think about halfway through, I'm going to switch and focus more intently on one study that we recently completed in healthcare settings and show you some of the data from that. When I was contacted to do this, the organizers suggested that it would be a good practice to use polling. And of course, I just didn't get there, so I don't have any polls, but I do have an Easter egg hidden in my presentation. So you'll notice as I go along, all the slides share a similar look, but there will be one that will be markedly different. And that's the one, of course, I stole from my PhD student, who's very much younger than I and does slides in a very different way, and I think a better way than I do. So I'll leave it for you to find the Easter egg when it comes along. So as I said, we started this about a year ago. And the notion of the project was to look at how organizations, employers and their employees are responding to the pandemic, and particularly how employees are experiencing the pandemic. And we submitted a proposal and we received funding from CIHR for the program of research, and then the New Brunswick Health Research Foundation and Research Nova Scotia also contributed some additional funds to allow us to do even more work. So it's been a very busy year, and we've been really focused on this notion of whether, first of all, whether, and if so, how, organizational responses affect employees. So do the traditional things we study in organizational research, policies, communication, leadership, social support, all those factors. How are they affecting employees who are faced with this sort of unprecedented disruption that we've all been going through? So we have a website, ohpdata.com, that has more details on the project. And my co-applicants and co-authors are Dr. Jennifer Dimmoff from the University of Ottawa, Dr. Stephanie Gilbert from Cape Breton University, Dr. Jane Mellon from Mount A, and then Rachel, Vanessa, Jacqueline, and Tabitha, who are all our dedicated research assistants, which some of you will recognize means they really did all the work and deserve much of the credit for what we've been doing. So we actually got interested several years ago in the notion of how organizations can respond to disease outbreaks. And organizations traditionally have ignored this whole topic, except every year when flu season goes around. And then we start cracking down on absenteeism and things like that. And we get very upset because people are off sick. And so, you know, it's almost predictable. Every winter there'll be stories in the media about how much time is lost through absenteeism and things like that. And we had a different approach, saying, well, organizations can also be a vehicle of public health. So if you want to influence the health of school children, you go through the school system because that's where they are. And for a large number of adults, they're found in workplaces. So policies in workplaces might influence how people respond to disease or deal with sort of diseases. We had a brief opportunity to look at this during a Norwalk outbreak at Mount Allison back in, I think it was about 2011. And they had this outbreak of norovirus that just sort of swept the campus, and they ended up shutting down the campus and you know, doing all the things that you do in, you know, cleaning the whole campus and policies of social distancing and promoted hand hygiene and food washing and all those sorts of things. And because we're university-based researchers and my colleague Jane Mullen is at Mount A, we had the opportunity to respond quickly and do a study. And what we were looking at is the notion that how, in this case, students perceive the organizational response might predict their own reactions. And in particular, we thought that fear would play a central role in this, that organizations in many cases, their messaging and their actions are in a sense designed to increase fear because it's that increased fear that might predict hygiene practices and social distancing, where at the same time it might have some deleterious effects in terms of predicting mental health. And that's essentially what we found in that particular study. So as I say, we also do a lot of research in occupational health and safety. This is a very common thing in safety, is you send a lot of fear-based messages. You know, don't do this or you'll get hurt. Don't do that or you can have this type of injury. And you're explicitly trying to increase fear in order to encourage the appropriate behaviors. In this case, now we want to encourage hand washing and wearing masks and social distancing. But we might also be influencing some other reactions, stress, adverse mental health outcomes, even stigma, where we might stigmatize others who either have the disease or are thought to carry the disease or whatever. So there's both a positive and a negative there. And essentially in our Mount Allison study, that's essentially what we found, is that kind of model, the students' perception of the university response predicted fear, and then fear drove those types of sort of infection prevention behaviors, as well as adversely impacting on mental health. So this is the sort of general model. When COVID-19 broke and we were putting together a research proposal for the CIHR rapid response grants, this is the type of model we were looking at. We thought that both your individual experience, your own exposure to the disease, maybe whether you were immunocompromised or dealt with, had people in your family who were immunocompromised, that would certainly increase your fear or anxiety. We were interested in looking at the employer's response to the outbreak, so their policies, their communication, and particularly how organizational leaders responded. We thought those things would drive sort of fear and anxiety, which in turn would affect well-being, self-protective behaviors, and then stigmatization of others. So that was the basic model we proposed, and then reality set in. So as the pandemic developed, what we thought was going to be a fairly clear-cut program of research really changed fairly dramatically, because the pandemic ended up segmenting the workplace in several different directions. So there's a meme going around you might have seen saying, we're not all in the same boat, we're all in the same storm, but in very different boats. And that's particularly true with the pandemic, because it's affected different groups of people and different occupations in different ways. So a large number of people became unemployed. Thankfully, that seems to be reversing now. But at one point, I think we went from an unemployment rate of just over 5% to something like 13.5%. So an immediate increase in unemployment as businesses shut down. We have a large number of employees. I think the peak estimate I saw was 5 million, which is roughly 40% of the workforce in Canada, who were working at home, or as some companies have started to say, work from anywhere. We have groups of employees who did their normal job as they've always done, with very little change. So think of, say, construction workers, where if anything, things got busier as everybody started home renovations. We have people who went to work as usual, with a few new conditions or precautions. So you wear a mask into work, and you might have screens around your desk, and you try to social distance at work and things like that. And then you have people who went to work as usual, but there's been some significant disruption of the workplace. So you're doing things very differently. Maybe your tasks have changed, or your assignments have changed. And that's essentially what happened in much of healthcare. They still have the responsibility of providing healthcare, but a lot of things changed. So we ended up doing a number of studies. As I said, I'm only going to talk about one of them today. But this is what we've gotten through so far. We had our longitudinal research is very much short-term, with intervals of a month or even a couple of weeks. We did an initial study of 2,000 US and Canadian employees, looking at early responses to the pandemic. We did a parallel study looking at retail employees, because of course retail workers, especially in essential retail operations, are the ones who had to continue to go to work. We have another 3-wave study of Canadian workers that's based on a representative sample of Canadian workers. We did a study of unemployed workers. We did several projects actually on work at home now. And the one I'm going to talk about today is a healthcare study where we targeted healthcare workers, and it's a multi-site project. So we went across several institutions. Frankly, not the best response rate from any given institution, but compiled all together, ended up with a larger study. So what I'll just mention in our general line of research, what we've generally found is support for that initial model. Fear emerges as a predictor of mental health outcomes and self-protective behaviors. And both fear and those sort of outcomes are influenced by some specific organizational conditions. We've been particularly interested in the role of leadership. And when I say leadership, we tend to study 2 basic styles that leaders have. One is passive leadership, or sometimes called laissez-faire leadership, which is really sort of an oxymoron, because it's the absence of leadership. It's leaders who don't really do anything. It's generally thought to be a destructive leadership style. And in fact, that's what we find when leaders are passive. Then fear increases, and adverse mental health outcomes increase, and things like that. And I'm not going to say the other end of the scale, because they're not opposites. In fact, one can be both somewhat passive and somewhat transformational. But transformational leadership is thought to be an effective style of leadership. It has those 4 dimensions listed there. It's sort of the behaviors that we think of when we think of what's a good leader. We think of someone who's a role model, who motivates and encourages us, who gets us to think in new ways, and who shows concern for us as individuals. So both styles of leadership tend to be influential in predicting people's outcomes. And as you might imagine, we found very high levels of stress. And in some of our research, we've included a screen for PTSD that's meant for the general population. And it has a cutoff where people are at greater risk for PTSD. And we're finding much higher prevalence than we would have thought. So in the general population, we're getting, sort of people passing that screen of 20 to 30% of our samples, which is much higher than I thought we would have got. We initially didn't have a focus on PTSD. It was early in the pandemic that stress researchers started flagging this as they're starting to see it. So we started to measure it, and sure enough, it's showing up in all of our samples. This is not a great graph, I know, for people viewing it, but it's the people passing the PTSD screen in the different regions. As you can see, in Atlantic Canada, it's was about 32% of the sample, I think, 31 point something. Lower in Quebec, much higher in Ontario, and then sort of middling in the West, I guess. Overall, it's about 30% of the sample, just over that, who passed the screen and would be considered at risk for PTSD. So the healthcare study we focused on, as I said, we ended up with data from 13 organizations, 596 employees from the different organizations, and there's a mix of long-term care and acute care in there. If you haven't noticed, this is the Easter egg, the slide where old people using PowerPoint use text, and my students all use graphics. So just to break down, as you would expect, most of the sample was female. About a third of the sample reported having contact with COVID patients. Most are frontline employees, of course. You can see the division, about 65% were in acute care, but 24% in long-term care, and the others, and then there was another category there. Most are full-time. Very few were immunocompromised, about 14%. And then we asked about their experience at that time. So this would be late spring into early summer of last year. So when we thought I think the second wave was just building as we were collecting data. And so some people reported that we asked what was going on in their institution, and about 29% said the cases were decreasing. About 30% had never seen any cases. 40% said they've seen cases, but not many. And only about 1% were reporting a lot of cases at that time. So it's kind of awkward to present these results now because I know the situation has changed dramatically in some jurisdictions. Especially Ontario, where things now are much worse than they were when we collected data. So whether these findings will generalize to now is a different thing. So in our studies, we've been looking at potential mediators. We had fear, and because we were dealing with a healthcare sample, we also included a measure of moral distress, where moral distress is the sort of stress caused by having to do things that you think are unethical or improper. And it's been used a lot in healthcare, so we included a measure of that, and we thought those two things might be going on. So we find, well, what is it that predicts fear? We looked at transformational leadership, passive leadership. We looked at access to PPE, because if you remember very early on in the pandemic, that was a huge issue. We looked at how much change there was in your workplace, because in healthcare, people were reassigned as some services shut down, and then they were reassigned to other duties, maybe screening for COVID-19 or something like that. And we also looked at safety climate, which is the perception people have that this is a safe workplace. So when we look at what statistically drives fear, these are all based on multi-level mixed model regressions. What seems to drive fear is if you have a good leader, it suppresses fear. And then if you had access to PPE, that also decreased fear. And when we look at moral distress, it was having, I guess, a bad leader. So leaders who aren't helpful, aren't supportive, aren't there, tended to increase moral distress. Having access to PPE decreased moral distress, and then the amount of change in the workplace and safety climate were all associated with moral distress. And in our model, we thought that those two sort of variables, fear and moral distress, would then lead to some other outcomes. And we looked at three sort of generic mental health outcomes. We have a measure of burnout, which is really focused on the emotional exhaustion component of burnout. So that feeling of just being depleted. We have Cohen's measure of stress, which looks at stress symptomatology. And then we have the screen for PTSD. And you can see that although we focused on fear in our general studies and in the healthcare study, it's significantly associated with all three of the sort of mental health outcomes, although the effects are much smaller for two of them than is moral distress, which has a much stronger association with burnout and PTSD. So I'm watching my time carefully here, and I'll just start to wrap up. So a couple of takeaways from the research we've been doing, and especially the research in healthcare. One is just the very high levels of distress we're finding. That's not only true in our research, there's lots of studies coming out now that are finding high levels of depression, anxiety, and various mental health disturbances in a whole variety of populations. Our data support this notion of fear, and in the case of healthcare, moral distress, as mediators of that relationship, suggesting that that's how organizational features are related to mental health outcomes. And the thing I really wanted to highlight is, and this is consistent across all of our research, is that the predictors of mental health outcomes are largely things that organizations can control. So we tend to think that, oh, of course, it's a pandemic. There are a bunch of features we can't control and we just have to respond to it, and there's nothing we can do. But actually what's driving a lot of the anxiety is, for example, the way leaders in organizations are treating employees. That's something we can deal with. And that's something I would suggest we even have an obligation to deal with, because all of the data coming out suggests that when leaders are able to deal effectively with their direct reports and with the issues they're confronted, that it really has a positive impact on employees' mental health. You know, access to PPE was, at the time of this study, a big issue. And again, this is something that we had control over. This was not some mysterious virus that nobody knew anything about. It was something that we did have control over, whether people had access to the relevant protective equipment. I know there was a shortage. You know, at the beginning there was this worldwide crisis. I just recently read an analysis of that pointed to, you know, a lot of the crisis was of our own making, and our reliance on just-in-time systems that are really ill-suited to these sudden demand surges. And again, the notion of change at the workplace has contributed to a lot of these mental health outcomes, especially for healthcare workers. And again, that's something we have some control over, that we're not just randomly responding to it. So now, things have changed again, and we're deep in it again in many jurisdictions. And, you know, just as we're sort of getting through a third wave, or we even hear people talking about a fourth wave. And I guess the academic in me has this cold view that it'll be interesting to see if these same factors hold up. But I think more practically and more humanely, it means that we really have to start focusing on how organizations as employers are responding to this. So there's a lot of literature on, leading in a crisis now, and certainly our data would suggest this is the time to dust off those findings, because the way leaders are responding and the way leaders are treating employees is likely to have a big effect, not only now, but in the future, because a lot of these mental health issues are not going to just go away once the immediate threat of COVID-19 has gone away. So thank you very much for your time. And I think we have time for questions, and I'd be delighted to hear any comments or questions you have.
Thank you very much, Dr. Kelloway. That was really interesting and insightful. We've got a few minutes. I thought I would selfishly ask a question from myself, actually. And I think you kind of touched on this at the end of your presentation, but looking forward into a sort of post-pandemic time when we are, returning to some degree of normal business, whatever that looks like. I'm interested in your thoughts on how the fear that you're describing that's been sort of cultivated gets sort of unwound or reduced, because I think that's something that organizations are struggling with. The level of risk is dynamic, and when it begins to reduce, how do you support employees in returning to a more normal state?
Yeah, and we're certainly seeing this in our work from home research. One of the things we're seeing is organizations are still, a large number of organizations seem to be under the assumption that at some point everything will be cleared up and we can all go back to work the way we always did. But in our surveys with employees, what we're seeing is a large number of employees who never want to go back to that. They want to stay working from home. Most, to be fair, want to do it on a part-time basis, work 2 days at home, 3 days, and the rest in the office. But the notion that we're going back to the way it was in the before time may be way too optimistic. And I think one of the things the pandemic has pointed out to us is where some of the weak points are. What are our organizational policies that don't really work? So the obvious one that you hear a lot of discussion on now is the absence of sick days for many employees. The lack of paid sick days is a huge problem that we really need to be addressing. But even in organizations, even frankly in healthcare organizations, I've over the years collected a lot of data there. And because of the nature of their operations, they tend to become obsessed with absenteeism until the crisis hits, and then absenteeism is not the issue we're dealing with, or not the main one, because we don't want people coming to work. So I think part of what organizations can do, long way to get to the answer to your question, is to start looking at their policies and how they're treating their employees and seeing if there are different ways to do that might make it easier for people to come back. And I think a lot of that fear will dissipate over time if we hit that magic point we're all hoping for, where everyone's vaccinated and the spread of virus is substantially diminished. Then I think fear will dissipate. But I also have a hunch it's going to take a long time. I mentioned I'm in Nova Scotia. We have very few cases. Our restaurants and gyms and things like that are fully open and to 100% capacity. I still talk to a lot of people who won't go out to eat, right? Because it's just that additional risk that they've been accustomed now not to taking. I think that's going to take a long time to deal with.
Thank you for that. That answer. We're pretty much at the end of time, Dr. Kelloway. You're getting lots of thanks in the chat for your presentation. So I think it's safe to say that folks appreciated your insights on this topic. Thank you very much for joining us today and sharing your expertise.
My pleasure. And for anyone, feel free to contact me directly if you have any questions or whatever.
That's great. That's
Okay.
so feel free to contact Dr. Kelloway if you have any further questions. Okay, thanks again, and that essentially brings us to the end of our last session. So at this point, we would still like if you complete the evaluation once you're done, once you go back to the timeline from this. I'm going to pass things back to Nicolia and Darkis just to give some closing remarks for the symposium. Before I do that, I just want to actually thank Nicolia, Darkis, and Alessandra Nenshi for all the work that they've done in putting this together. Excellent job, guys, really getting a lot of good feedback. And also to our U Ottawa CPD team for all of the excellent support that they've given us. So I will give it back to the two of you to make some closing remarks and do a prize draw.
Awesome. Thanks, Mike. And thanks everyone for attending the symposium. We hope that you thoroughly enjoyed it. There we go. Okay, so I'm Nicolia, and we're going to do our prize draw. So if Cassandra, if you could share your screen. We'll pick 2 winners. Congratulations. And we'll do a second draw. Wonderful, Mrs. Joshi. So we will be contacting both of you and the prize winners from yesterday directly, so to claim your prizes. So just a few remarks. I'll go over and then Darkis will finish up. Later this afternoon, you will receive an email with a link to the overall symposium evaluation. So we'd really appreciate it if you could take a moment to complete the surveys so that we can further improve our next event. And we really do appreciate that feedback. Furthermore, certificates of attendance will be released via email within 2 weeks. And as we've mentioned at every session, all of the sessions are recorded, and the recordings will be posted on the virtual portal within 1 to 2 days, and they'll remain there for 1 year.
Oui, alors c'est la fin. J'aimerais remercier les conférenciers pour leur participation à l'événement. C'est certain que c'est différent de participer à un symposium qui est virtuel comme ça. C'est pas habituel. Il a fallu qu'ils s'habituent au mode de transmission. C'est sûr que ça a pris faire des pratiques avant l'événement en tant que tel. Donc, merci beaucoup pour le temps que vous avez passé ou consacré à notre symposium. Merci aussi aux 6 de l'Outaouais, à l'Université Saint-Paul pour leur participation à l'organisation de la version française du colloque. Comme le mentionnait Nicolia, cet après-midi, vous allez recevoir un lien pour évaluer la session de façon plus générale. Donc, on vous invite, s'il vous plaît, à compléter cette évaluation-là. Ça va nous aider et nous permettre de rectifier le tir si on a à le faire là, pour l'année prochaine. Vous dire également que vous allez recevoir vos certificats de participation d'ici 2 semaines, que les sessions ont été enregistrées, seront disponibles sur le portail de la conférence. Donc, je pense que ça fait le tour. Merci à tout le monde de vous être inscrits, d'avoir participé. Puis on espère qu'on va vous revoir l'année prochaine pour une prochaine édition. Alors, merci beaucoup. Bonne fin de semaine. Faites attention à vous autres.
So thank you very much, everyone. Again, thank you to all of our speakers for their time and expertise. And we hope to see you again, hopefully in person, for our next symposium. So have a great weekend, everyone.